So let's get going. Thank you for joining us today officially. My name is Lisa Vigil Schattinger. I'm the founder and executive director of Ohio End of Life Options. For those of you unfamiliar with our organization, we are a 501c3 nonprofit that advocates for patient-directed end-of-life care. So in addition to talks like the one being given today, we also raise awareness about and advocate for medical aid in dying law for the terminally ill in Ohio. Today, we are featuring our talk conversations for today with Maryjo Prince Paul, Dr. Maryjo Prince Paul. She will present her talk first, and then we will go into a Q&A session after. And so I had mentioned a little bit earlier, we'll be working with both the chat and participants features. If you enable the participants window, you'll be able to raise your hand. And if you enable the chat window, then you can also chat if you want to everyone or to me. I will try and moderate this, but we'll do that following Maryjo's presentation. So for today, I'm very pleased to introduce Dr. Maryjo Prince Paul. You saw from the description of this talk that she has over 30 years of experience in hospice and palliative care as a nurse practitioner, a researcher, and she's an associate professor at the Francis Payne Bolton School of Nursing at Case Western Reserve University. Across Ohio and nationally, she brings an incredible combination of experience, professional, a firm base in ethics, as well as her whole heart to end-of-life care. We are so incredibly fortunate to have her on our board of directors and chairing our healthcare coalition. That provides a place for healthcare professionals to gather in order to support our mission. So with that, here is Dr. Prince Paul. Thank you.
Well, I want to welcome all of you. Thank you for joining us today at 2 o'clock. I think most of you probably are joining other people at 2 o'clock in Ohio, that is. So we're excited to have you here with us today, and we really want to begin to have this conversation and for us to have this platform to do that. We've given you a lot of materials. I know Lisa sent that out to you along with the invitation for you to review and read as we continue to shelter at home. So if you haven't had a chance to look at those, I encourage you to do so after the webinar today. And if you have, I would really encourage you to ask any and all questions about what you have read. My hope today is that I'll be able to review some of the information in those documents. So just to start, over the course of these past 3 weeks or 4 weeks, I guess it is now, I've really found that we can make good use of this time to reflect on what matters most in our life. We've been sheltering in place for a while now. And I don't know about you, but this has been somewhat of a silver lining to have my entire family home with me and my husband. And I also want to recognize that we have seen great tragedy in our country and our world during this pandemic, and perhaps been witness to the loss of many lives, and our hearts go out to those and their families. Perhaps through this tragedy, though, it's allowed us, I think, to have some more mindful and more intention about the way we think about our daily lives and how we want to live our lives and how we would like to perhaps live until we die, and even how we may see our own death and dying happen. And even though this idea of death, because for many of us it remains still just an idea, it's very much part of our life cycle, and the journey to physical dying actually begins at the point of birth. Thinking and talking about our own death usually remains in the background, though, at least until its prospect becomes more probable or even imminent. Of course, death can occur without warning, as it does with trauma and sudden unexpected accidents. However, most often, death is more insidious and is the result of a chronic illness or a disease that is prolonged. And we simply, as Americans, haven't created space to talk about it. For those of you who have, I commend you for doing that. So how can we turn this around to incorporate these conversations into everyday living and to really normalize this most certain experience in our lives? So today, I plan to provide you with some ideas about how to begin to do that and to have these conversations, providing you with tools and resources to assist you with that conversation. And my secondary hope is that I hope this stimulates so many questions that we can talk about as a community. So my objectives today is to identify trends and contextual influences related to serious illness outcomes in advanced care planning. I will discuss some relevant facts and figures about the current state of advanced care planning in the United States, and then finally review resources available to you to improve communication about advanced care planning. So I just want to start with some facts, and I'm sure none of these will surprise you, that we live in a death-denying society. And most all people in modern America think the time to decide or even talk about healthcare choices is later. We'll do that later. And these conversations are rarely considered during routine days of living. Rather, they're made during a crisis. And I've witnessed many of them and witnessed and participated in many of those crises when both patients and their families are laden with anxiety and fear and the lack of time to make mindful, reasonable, and logical decisions about what's next or what to do when this happens. And it's so easily today to be lulled into the belief that death may be somehow postponed, or, as some prominent figures have forecasted, even avoided. And I don't want to take away from the enormous gratitude we must have for the advancement of science and technologies, as well as the burgeoning field of stem cell biology and regenerative medicine. We can certainly almost replace almost all body parts these days, if you think about it. And all of these advancements have catapulted the prospect of delaying death to a much greater extent than previously ever thought possible. But it's still the case that over 70 million Americans over the age of 70 are alive in our country today, and life expectancy continues to rise. That's a good thing. Still, death will inevitably occur. And if you haven't had a chance to read my paper on upstreaming these conversations as a public health approach, starting at the kitchen table using plain language and less medical terms, please take a minute to do so after the webinar. It's a practical piece that offers a ton of tips. And Lisa included that in as an attachment to your invitation to today's webinar. So I think what's important that we first start with definitions. Words matter, right? Words matter and definitions matter. And sometimes we use these words interchangeably. Advanced directives are documents that are part of advanced care planning. And care planning is the actual conversation or the process. It's making decisions about care you would want to receive, and I underline this, if you become unable to speak for yourself. That's the whole purpose of this process and this plan and these documents, is that they become your voice when you are unable to speak for yourself. These are your decisions to make, regardless of what you choose for your care. And those decisions, this is another piece I should have highlighted, are based on your personal values, your preferences, and discussions that you will then hold with your loved ones or those considered most important to you. So I like to include this slide, the difference between the rhetoric we hear and then the reality that I have been, I guess I would say, privileged to witness, even walking away from some of the most difficult situations. I think this reality on the right-hand side still rings true. But the rhetoric that we hear at our kitchen table and in our society, and that maybe as we perhaps bring up at dinner parties, is I don't want to talk about it. That is so depressing. Why would you ever want to discuss that? And I often hear young people say this to their parents or their grandparents. You aren't going to die. Why are you talking about this? Or for that matter, why are you even bringing it up? One of the most well-respected physicians in my space of hospice and palliative care, she's also an intensivist, which means a physician who specializes in the intensive care. And this comes from Frontline, which is a documentary of facing death on Frontline. It's a PBS series. She says, nobody wants to die, and nobody wants to die badly. There's almost always something we can do to put off the inevitable. And therein lies the complex and very complicated space of making decisions, and making decisions when we often don't have these documents or haven't had that conversation. I also want to say that we often plan and research, evaluate, and discuss more about materialistic objects we aim to purchase, like cars, lawnmowers. We are great consumer reports people, dishwashers, refrigerators, even chainsaws. Think of something. We do that work more than we do thinking about our own death and planning for that will happen to exactly 100% of us, with potentially greater consequences on those left behind as compared to those materialistic possessions. So some interesting figures that I want to pass along to you coming out of the Conversation Project National Survey in 2018, and then a CDC poll that happened in 2014. We're going to spend a significant amount of time later on in the conference today about this Conversation Project and really utilizing that as a great launching point to start to have this conversation. But 92% of Americans say it's important to discuss their end-of-life wishes and their care, but only 32% have actually had a conversation. 95% of Americans say they would be willing to talk about their wishes. And 53% even say they'd be relieved to discuss it. And then 60% of people say that making sure their family is not burdened by tough decisions is extremely important. And I think all of us attending this video today would say the same. Yet 56% have not communicated their wishes at end of life. So what this says is we have a lot of folks who really think this is important. They have willingness to do it. They don't want their family to be burdened, yet they haven't done it. And that's what this next slide says. So what I really want to highlight about this is some great work that the Kaiser Family Foundation did in a survey on aging and end-of-life medical care back in 2016. These data actually hold true today. The percent who say they have had their end-of-life wishes for medical treatment in a written document, only 27%. And even though that you see 51% of those folks by age are 65 years and older, it still remains the case that in totality, it's 27% of those surveyed. And among the 72% who do not have end-of-life wishes in a written document, they ask, what's the main reason that you don't have it done? And 50%, nearly 50% of the people just say, I haven't gotten around to it. And that's really goes back to what I shared in the beginning about we'll just put it off until later. Unfortunately, the later often comes sooner than we would have hoped for. So we also have these misconceptions and realities about talking about and having these kind of conversations. It's going to make you more depressed. It's going to take your hope away. And actually, it might make you die more quickly. And that's actually not the case. And we have strong data to support that. So patients have had no higher rates of depression when provided with honest information. And in fact, later on, I'm going to show you a a slide that shows when physicians or medical providers provide honest information, or what we call significantly honest prognostication, or the predictability about what's happening to you, the people actually have more time and they free up space in their lives to do important work and to have important conversations and to get their affairs in order. Patients given a poor prognosis with no chance of cure actually remained hopeful when having honest discussion. And advanced care planning does not affect survival rates. So it's not the case that if you do this work, your death is going to come more quickly. However, here's what we do know about what people are concerned about, what you all may be concerned about, or what you have actually been concerned about if you've been a caregiver of those loved ones who are seriously ill, or if they have a chronic illness where you know that over a prolonged period of time, you will and they will have to begin to start making decisions about how they want their care to be provided, what they believe is quality of life for them or for you, because for each of us, that is very different and it's very personal. So all of us are concerned about the fear of pain when we die. Most all people are. And we can also talk about pain as is it just physical pain, or can it be psychological pain, emotional pain, spiritual pain? Many people talk about financial burden, and I think this is obviously a very significant factor in our days today. Concerns about invasive, painful treatments and how might they interrupt their quality of life, their independence, their function, their daily functioning. Having the dependence on others, especially if you've been in an independent role and therefore role changes. And then elderly, caring for the sick. And so as we know today, the common situation that we have in our country is the 60-year-old daughter or son caring for their 80 or 90-year-old parent. And what if each of those relationships have their own significant burden in terms of healthcare and healthcare response? So we first want to dispel some myths that I have not only heard my colleagues talk about, I've heard the community talk about when we get together and share some of our stories, and that advanced directives, when you have them done, they should certainly solve all problems. And that is actually not the case. Now, we don't want that to deter any of you and shut this off and run away and go do something else. But there is not a single document about your health care and what you do and do not want that can adequately or accurately predict every situation. So it can't solve every problem, but these documents can serve as a compass, or what I say to families, a GPS, to help direct not only you as a provider or a patient or a family member, but that healthcare team who is communicating with you. Now, this one might surprise you, that family members are what we call surrogates, or we often use this term, proxy decision makers. They're good sources of predictions of what the patient would want. Meaning, if I just assume that my husband would know exactly what I would want. And that is actually not the case. And I'm going to show you some data to support that later on about surrogate decision making. This is a myth, because unless we have a conversation, we can't assume the other knows or doesn't know what we want. So the bottom line is is that we have to talk. We have to talk to one another. So just so you know the law, and I'm going to specifically talk about the state of Ohio when it comes to proxy decision making. Again, this is when you have lost your ability to communicate yourself. Otherwise, we wouldn't be having this conversation. So if you have decision-making capacity, meaning you do not lack decision-making capacity, you have abstract ability to think and to make decisions about your health care, obviously, you're the one that we would be turning to have those conversations. When that doesn't happen, and you don't have these documents, and we have to turn to your next of kin, there is a specific order in the state of Ohio, and this is pretty similar in most other states, that we would turn to the spouse first, then the adult child, and then the parent. So that's actually the law about the proxy decision-making order in the state of Ohio. And so why do we turn to family members when we don't have these documents? Because you're going to hear me say later that some people choose not to signify their family members as their durable power of attorney for healthcare or their agent to speak on their behalf. Instead, they want to designate another person who may share those same values and the person who will do what they have asked them to do. But why we have to turn to family members to make these decisions when these documents don't exist, it's based on three assumptions. We believe that they have shared values, that you know the person the best, that my spouse would know me the best, and that he or she would have his or her best interest at heart about what I would want. And so that's just a brief overview about proxy decisions and why we turn to family members. So here's this interesting slide on family members and surrogates. Are they good sources of predictions of what the patient would want? And you might find this very interesting. They're only accurate 70 to 75% of the time. So even if a patient has an advance directive, the surrogate often does not know what it says or its location. So that is a critical piece that we want to talk about today. It's not simply enough for you to fill this document out and put it away. And in fact, we don't want you to put it away. When you fill this document out and when you get to that, the conversation has to exist concurrently with that document. It's not enough to simply fill it out, especially if the surrogate doesn't know what it says. Because what if it's the case that when they do finally find it, because you haven't shared it with them, and you're in a position where you can't communicate or you lack decision-making capacity, and it's the first time that they have seen what you selected on that document, what if they're in disagreement or have discordant goals? That's where conflict exists and happens. And it often happens in the inside walls of an intensive care unit where there's most always chaos going on because it's an intensive environment. One final comment about surrogate decision-making is when they're asked to match the acceptability of various health states as an outcome. So we give a health state as an outcome, so inability to eat. And then we say, would your mom or dad agree with that, with what the patient said? And that agreement is at 60%, which goes back to the first bullet point, that the accuracy is 70 to 75%. So even when we think that surrogates should know, if you haven't had a conversation, I think you might be surprised in what you'll find out when you have it. So this is an interesting slide that, again, the Kaiser Family Foundation submitted through this poll that they submitted in 2016. And in both of these orange spaces, what you will see is about honesty and prognosis. And the first question was, who do you think should have the greater say in decisions about which medical treatments to pursue for terminally or seriously ill patients who are near the end of their lives? And without a doubt, an overwhelming 87% said the patients and their families should be the one to make these decisions about their treatments. And that just seems logical to all of us. But I want you to think about perhaps how many times you have said or you have heard others say, we're just going to do what the doctor thinks is best. Now that might be how you've lived and how you've been raised in the culture of your home and your decision making. But that puts so much burden on the healthcare team, and it also doesn't take into account perhaps what you value or what is important to you. When asked when a patient is seriously ill, do you think it is more important for their doctors to emphasize hope, or more important for doctors to be completely honest, even if there is a little chance of recovery? And again, an overwhelming majority of people in this poll said, we want you and we need you to be completely honest. Why? So we can get our affairs in order, so we can communicate with those most important to us, so that we can get organized with what we have left to do, and we can make logical and conscious decisions about how we want to live our life until we die. So I want to quickly talk about this big word, prognosis, and what that means when we say prognosticate. So what that means is just a prediction. And in fact, it's important to understand this word when we are talking about being considered terminally ill. So we have some guidelines that terminally ill is defined as those patients who have been predicted to die within 6 months or less by a best medical educated guess. And that means, as compared to those who have maybe had a similar illness and experienced a similar disease course, would you be surprised if that person would die in the next 6 months? Here's what we know, though, about prognostication is that greater than 60% will over-prognosticate. And this study actually was looking at physicians. I can say that most healthcare providers do over-prognosticate or over-predict the survivability of patients. And this is challenging because we don't have an algorithm that says exactly this is the way it's going to happen. This is when you will die. We have a good sense, especially in certain diseases that are more predictable and have a more line that's more straight in its decline versus those that ebb and flow over time that follow a more prolonged and protracted, like heart failure, like dementia, neurological disease, end-stage kidney disease. Those are the more prolonged and protracted diseases. Advanced cancer can be somewhat more predictable. And again, why we need good prognostication or good predictability in our disease process is so that not only can patients need that information to plan, but families need that information to plan. And collectively, you need that information to plan to have a conversation. So I want to start getting into some of the forms and what forms we have in the state of Ohio. The forms that we have in the state of Ohio that comprise our advanced directives are called the Living Will and the Durable Power of Attorney for Healthcare. So just to give you a brief overview of how this came into play, was largely based on landmark cases of Karen Quinlan back in 1976, Nancy Cruzan in 1990, and then the very long protracted case of Terry Schiavo. But all of those cases, primarily Quinlan and Cruzan's case, allowed us to springboard the Patient Self-Determination Act, or what's called the PSDA. What this says is it requires all healthcare institutions to inform patients about their right to complete an advanced directive, including their right to refuse life-sustaining interventions, including artificial nutrition and hydration, mechanical ventilation, dialysis, cardiopulmonary resuscitation, or CPR. Now, why do I have yes, no here, or a Y and an N? Because all that a healthcare institution or the intake person that's actually asking you this question, whether it's outpatient or inpatient, you've probably been asked this question: do you have an advanced directive? And typically, people will say, yes. So we've watched this. We've actually done some observational studies with this. Most people don't know what an advanced directive is, but the only requirement or obligation that the healthcare institution has is to simply ask the yes/no question. They don't have to ask you, do you know what that is? Do you have the actual document? Do you have it with you so that we can scan it into your electronic medical record? None of that is required. And in fact, all that they have to ask is yes, no. So there's an additional problem here, because if a patient understands an advance directive, or the person might go on to say, you know, it's those two documents, that will and the durable power of attorney. When people hear those two terms, their mind will automatically shift to the legal document, that financial document, or estate planning document, not a healthcare document. So if they answer yes, is it really a valid response to the question? But so I wanted to cover that just so you all know. That's where we as healthcare consumers really have to take responsibility in taking the next step. Yes, we have it, and here it is. And that's where the resources come in a minute when I begin to talk about that. So in 1991, Ohio passed this legislation to enact advance directives. And then in 2016, we did a small revision to the forms. So I'm going to talk to you about how each of these work. I'm going to give you a couple of hints about some of them, and we're going to try to pop on the website. I know Lisa has also provided you with this link. So many people just don't know where to go to find these documents. And we've given you the actual link that's been endorsed by the Ohio Bar Association, and it's from the Ohio Hospital Association. And these documents are legal documents, so you can access them very easily and print them off if that's the way you would like to start. The other thing is, everyone says, oh, I need to go to an attorney. I don't have an attorney. Oh, I need to find 15 witnesses, or it has to be notarized and I don't know a notary. So we need to talk through that. It actually is a pretty simple process. And then the last piece is, what do you do with them? And I'm going to tell you what not to do with them more than what to do with them, because that's the case. I often find out they're in a bank box. Never put them in a bank box. All right, so this is a really tough little image that I tried to screenshot on here, but I'm going to flip onto, hopefully this works, the Ohio Hospital Organization, and show you this document. And you had this link as well. It worked. All right, so this is, oh, did it go away? Or can you still see it? Lisa, you're muted.
You might have to tab through to see what you're displaying on your screen.
No, can you see this picture of the,
No, not the
okay.
healthcare account.
All right, hold on. Let me see if this will work. All right, now can you see it?
No.
Oh, you can't?
No.
Oh, sorry. I did what Ben told me to do too. Dang it. Okay, well, this document will have, 1 second, I'm going to flip back to the screen. Sorry, that's not working. So maybe you all can, or you have these documents in front of you, but that link for some reason is just flipping out and not letting me show you what the document is. So it is actually both documents when you open up the State of Ohio Advance Directives. The first document is the healthcare power of attorney, or that designation or that designated person that you will designate to be your voice, and that person who will speak for you when you are unable to do so yourself. The living will declaration is the second document in that packet of documents. And then there's also a section about organ donation that is in this packet as well. And so let me talk about a little bit about each of those in turn. So the living will, that's the second document, allows you to decide and document in advance the type of care you would want to receive if you were to become permanently unconscious or terminally ill and unable to communicate. Now, that is very important to realize, that this document does not become, the living will, does not become operationalized or active, if you will, unless you are considered terminally ill or permanently unconscious. A lot of people don't understand that. So what happens here is, these are your words. It is your legal form of your words that say, This is what I do and do not want to happen to me. Or I do want this to happen to me if I become in a terminally ill situation and I'm unable to verbalize this. If you are considered terminally ill, this becomes active at that point. People will often ask me which one of these two documents should I have if I were to fill out one of them. And here's my response. You need to have both of them, because the healthcare power of attorney enables you to elect someone to make decisions for you, no matter if you're terminally ill or not. So it may be the case, and probably is most often the case, that you're not terminally ill, and you may have lost your ability to have decision-making authority for whatever reason. It might be because of a surgical incident. It might be post-anesthesia with a complication. It might be lacking decision-making capacity because of a neurological condition. So this is why it's critical that you've designated someone to and selected someone to be your voice for you. It is not a financial power of attorney. I want to say that again. So I'm sure there will be lots of questions about these two documents. At least I hope there is at the end, and we can talk about this more. What I also want to say here, and I think this might stimulate some more questions that we may have to have another webinar on, and I'd be glad to do that if it would be helpful, is that although this is a legal document, this is not a medical order, which means you don't need a physician to sign this, nor will a physician sign it. All that you need are two witnesses unrelated to you. So it could be a neighbor, if that neighbor is unrelated to you, and someone that's coming to your house for dinner one night, who is, well, not right now, but soon, who will be able to sign that for you. Two people who are unrelated to you serve as witnesses to your signature. If those two people aren't available, and there is a notary that is available, the notary is all you need, but you don't need to have a notary, nor do you need to have an attorney sign this. It is not a medical order, which means that if EMS is called, meaning 911 has been dialed and the emergency personnel, emergency medical system has been called and activated and comes to your home, they cannot follow the advance directive because it's an emergency that is underneath of why you called them. Therefore, they have to follow emergency protocol, which means transporting you to the nearest acute care institution. So we can probably talk a little bit more about that in terms of whether you have a do not resuscitate order, and that is a medical order. If you have a do not resuscitate order, and it is a medical order that is on your refrigerator or in your home, and emergency personnel are called, then emergency personnel have to follow that because it is a medical order. But the advance directive as a durable power of attorney for healthcare and a living will collectively as a document, even though legal, is not a medical order. I wish we could ask questions right now. So write them down if you have them, okay? Because I'm sure some of you have questions about all of that. It's lots of questions exist with this, so please don't hesitate to ask anything about this. I'm just checking my notes to make sure that I covered everything that I wanted to there. So we're headed into the resources and apps. I know some of you are still paper and pencil oriented. I know that I am, even though I've been forced, I think, in the last 4 weeks or so to become more digitalized, more technologically advanced. And there are great benefits in that. That's why I want to show you that these resources are both paper forms and they're apps that you can download, or web-based that you can even print off after you finish them. So we need to get this conversation started, and I'm going to show you all kinds of resources that I not only have used myself, but I have tested in the classroom with my students who range from the age of undergraduate students 18 to 20 some, and then my graduate students to get their feedback on what they think has the most utility and what's actually been easiest to use. I actually used this and the next one, hello, with my family the other night. So this is a card game called Go Wish. And this foundation was established and funded by the Archstone Foundation, CODA, in 2005. And it was to develop and test a program to educate assisted living residents, their family members, and the facility staff about end-of-life care options and advanced care planning. The Go Wish game was developed within this project to fill a need for a way to stimulate discussion based on values and wishes on end-of-life care. So this is what it actually looks like. I'm going to show you. It's if you like cards and card games, it's a really fun way to get something started at a dinner table. You organize these into classifications as very important to me, somewhat important to me, and not important to me at all. And you even get a wild card. Can you see that? Okay. So here is one of them, to say goodbye to important people in my life. And then you simply work with another person dividing the deck and organizing that into these three categories or ranking them in terms of importance. And then you hold a discussion about that. So if you go online, I gave you the website on the bottom, this gowish.org. You can actually click on this link. It takes you directly into this website, and this is digitalized in a web-based format that you can not only input your answers, but then you can print this, and you can use that perhaps as a discussion in dealing cards and then ranking them and then printing it out. So if you find that is a easier format to follow, or maybe it just feels right to you to work with as you hold these discussions with those around you, this can work with 2 people and up to 6, they say. Although they're on the website, you'll see that organizations are actually starting to use this for leadership training, which I find very interesting because it does allow people to really think about these preferences and values and where you rank them in terms of importance. So this is the hello game. This is a conversation game. I want you to just notice, if you quickly can, the red bar at the top of the slide, and look what it says. We're currently sold out of the home edition. Oh goodness, my hope is that not only did everyone sell out of, paint by numbers, Amazon, and books, but people turn to these kind of board games. I wish I had a way of doing a survey across the country to see how many of these were purchased during this pandemic. But my hope is that when we are sheltering in place, this is just a wonderful way to hold space and create space with people to ask these questions. This is the game that most of my students prefer, and this is the game that my family and I participated in the other night, which was quite interesting. We talk about death and dying very openly in my family, as you could quite guess, but these booklets that you have, or that they pose, offer really poignant questions. And if you think that you can get through all 32 questions in one sitting, we only got through one. And that's because what happens is you start to talk about other things. Once somebody says something, the other person might say, oh my goodness, I had no idea that that's what you thought. Where did that come from? And then that might stimulate something about what happened when they were growing up. And that's what happened in my family, from something that my son, who is 21 years old, witnessed early on in his life with a traumatic death experience and what happened with the funeral. And he just said, I don't want that for me. We would not have known that, and I didn't know that that had changed from when my father had died and he had been with me during that death. So just because I had that conversation when he was younger, we hadn't had that conversation in 7 years, and his value had changed. And not only did his value change, but what he wanted for his death experience in terms of his funeral had changed. So it was one question in this booklet that stimulated that in our family conversation. Let me just read one of the questions. This was another question that we answered and we got way off track in our family. What music do you want to be listening to on the last day you're alive? And so this, thank goodness we all have, or most of us have iPhones and we can just push our playlist. But then, oh, my playlist would not be what I want played at my funeral. So here I go again with offering the conversation has to exist, and it can't exist in isolation. It needs to exist with the people that you hold most dear to you. This is probably one of my most favorite new mobile apps called mydirectives.com. Consumer users in 50 countries. This actually helps record your medical treatment wishes, your preferences, organ donation status, and critical information on this device and in a format. It's free. It can be used on Apple and Android users. You can also use it on your computer as well. It's in use in 75% of hospitals and 5,200 dialysis centers. Now, why do I like to hear this? Or why do I like this product? And I'm not endorsing any of these products. I mean, there's so many available, and there are so many available that are also free. Most of them are free, quite frankly. What is wonderful about this is that you can, your voice is recorded, yet the institution must be a user for it to interface. So that's the only downside of mydirectives.com. I've given you this link. It'd be really helpful for you to just click on it. There's a video in the top right corner of the homepage of this website that gives you a really brief tutorial on how it works and what it asks. So you might want to look at this. I'm also going to say that if you have distant caregivers or distant family members, this allows for sharing of information once you click them on as users to go into your platform and see it. Then they can share theirs with you. So that is mydirectives.com. This is a video decision support tool called acpdecisions.org. It's a not-for-profit foundation of a group of clinicians that actually designed this, dedicated to empowering patients, families, and providers in advanced care planning. The support tool is crafted that with over 300 videos in the video library in these categories: video decision aids, freestanding educational videos, caregiver videos, and training and implementation videos. So what I found very helpful with this is the description of what CPR actually is. Because what most people believe is what they see on Grey's Anatomy and what they see on television. And let me just tell you, that is not the reality of what CPR is in an acute care setting or even out of hospital. So again, I think what it takes is getting in there and really looking around. Again, a video tutorial at the top of it. It's like a YouTube video that you can look at and use. Cake. Cake is also one of my new favorites, and this can be used on any device, including your computer, tablet, and mobile, and it can be downloaded too as a paper document. Same kind of platform. It also digitalizes, puts it on a technological platform that allows you to share it, and it is secure as well. And I've given you that website too. If I had more time, I would jump in there and show you all of those. All right, so this is the one that Lisa, can you show me a hand of how many minutes I have left? 5 minutes, okay, thank you. So the Conversation Project has just been journeying across our country and beyond. Oh my goodness, this starter kit is available in multiple languages. This was started in 2010 by Ellen Goodman, who most of you know is a Pulitzer Prize winning writer. She had her own lived experience with her mother's death with Alzheimer's, and that spearheaded her desire to say we need to talk about this. She did not know what to do. She did not know what her mother wanted, and collectively over the years she gathered professionals and experts from all disciplines and has put together very brilliantly this conversation project and conversation starter kit. We have given you that website as well, and on the next slide I'll advance. It shows you an example of what one of the slide or one of the pages looks like in this format. But what it does very simply is it sets it up in a get ready, get set, go format. And it allows you to work through each phase to determine how best you can determine what your goals and values are. And then it helps you organize those thoughts. And then it really asks you some poignant questions about how to start thinking about who you would share that with and how you would share it. It's a guide that you simply cannot complete in one sitting. It's meant to be completed as you need it throughout many conversations. And it's really to provide a shared understanding of what matters to you. This is a screenshot of some of the questions that, again, are ranked, ordered from really one of no importance or giving you the absolute opposite anchor of what 5 is. So how long do you want to receive medical care indefinitely, no matter how uncomfortable the treatments are? And yes, there are some people who would make that choice, all the way to, hey, listen, quality of life is more important to me than quantity. And then I would ask you to write down, well, what does that look like? What does it mean? Can you give me an example of what the most awful situation might look like for you and what the best situation would look like for you? And those questions are asked throughout this project. So we could have an entire webinar just on the conversation project. And it's actually been journeying across the country as dinner and conversation. So you literally travel from house to house having conversations over these various chapters in this kit. For those of you who are basically binging on Netflix these days, here's one. It's incredible. It's called Extremis. I use it in almost every class I teach. Dr. Jessica Zitter is a graduate of Case Western Reserve University Medical School. She went on to write Extreme Measures and then went on to become the lead in this documentary called Extremis. And it's her journey through what it's like to be in an intensive care unit and what's happening with our current medical culture, what she calls the end-of-life conveyor belt, where people are intubated, catheterized, and even shelved away in care facilities to suffer their final days alone, confused, and often in pain. What she presents is how this can potentially shift if we have conversations at the table before this happens. I think it's about 24 minutes, so it's not long. You can't be binging on that. All right, so let's head on into the end of this so you all can start asking me questions. I want you to ponder these questions, perhaps today, maybe even tomorrow, because tomorrow is an important day. Whom do you trust most to make healthcare discussions on your behalf if you were unable to speak for yourself? Would you or would you not want efforts made to prolong your life if your brain were permanently injured? And this is important, with no expectation of meaningful recovery. And I ask you to shelf that last phrase in your brain. If you are ever in a position to have to make these decisions for a loved one when you've been told their brain is permanently injured, you should be asking, is there any expectation or hope of a meaningful recovery? And only you can know what meaningful is if you've had a conversation with the person for whom is injured. Have you had the conversation, and do you have an advance directive? So here are my final comments to you. Please do not store your advance directive in a bank box, a locked safe, or under the mattress. It's not money, although I think it's worth more than money. We can't get to it. we don't know. The whole purpose of that document when it's completed is those are your words. Those are your words when you can't speak. So we don't want them hidden or locked away. We certainly want our healthcare providers to know. And so you've got to share those with your healthcare providers. Not only do you tell them that you have it, you want to tell them that you want them to upload it to your electronic medical record. It's at least one step further in this somewhat fractured healthcare system that we have. Revisit these documents at turning points or milestones in your life, birthdays, when your children turn age 18, when they become legal, right before you go on a trip, when you become Medicare eligible, when you become married, possibly divorced, when you have birth of your children or grandchildren. The AD is not perfect. Remember that it's impossible to predict every healthcare scenario and the outcomes that come with them. And they never happen in one sitting, rarely. It's a process and it takes time and it takes discussion. So you all, tomorrow is National Healthcare Decisions Day. So yes, Lisa and I planned this mindfully. It is the day that our country should participate in having these conversations and getting these documents at least pulled out and prepared. So we hope that you will actively participate in this tomorrow somehow. Maybe it's watching Netflix and that documentary. Maybe it's simply reading one of the papers that we gave you or downloading the healthcare documents. But we're really glad that you joined us. And I know I've probably gone way over time, which is not unusual for me, but I thank you. And I welcome all questions.
Thank you, Maryjo. So now we're going to go on to questions, but before we start that, I want to just go over a couple of things. We will get back to you with the survey so you can let us know how we did today and give us suggestions for improvements or changes, as well as additional topics. We'd like to hear from you on what you want to hear about. And then please share these events in the future. Invite your friends to join us on these talks. Our next one is on April 22nd at 2 again, featuring Sarah Kappas-Peck. And she is a personal historian and she'll share how to get started on you organizing your personal history. And then I always have to say, if you would like to support Ohio End of Life Options, your donations are always appreciated. You can go to our website, and then in the upper right-hand corner, you'll see the donate button. Our website is ohiooptions.org, and we thank you for that support. And so now we're going to get on to a couple of questions. Again, you can I see a couple in the chat button. You can also see, I'll try and see if they're raised hands. Maryjo, are you able to see those in the chat button, chat field? Or do you want me to read them?
The question, I am. I am able to see them. So let's address Susan. Can we address Susan's question? My greatest fear is developing mental incapacity without a terminal illness, such as Alzheimer's, dementia. What are the options? So Susan, you're still with us. I see you, I think. Yes. Hi. It's a great question. And I'm going to say to you that I think that you're not in the minority at all. The majority of not only actually my younger students, but my patients' family members have shared this with me. And your control is the documents that you have in front of you, to make sure that you not only fill them out, but you have the conversations about what you do and do not want in the face of losing capacity with Alzheimer's. As you know, Alzheimer's can be a very prolonged course of a process, and very hard to prognosticate in terms of identifying when a person is terminally ill. We have criteria that we do use, but again, it's difficult to prognosticate that. So what I have to encourage you to do is just make sure that you have the durable power of attorney and your living will filled out, because that living will, even though it doesn't kick in, if you will, until you're in a terminally ill state, it does serve as a GPS to guide conversations. So when perhaps a family member says, I know that mom didn't want to have artificial hydration and nutrition, it is absolutely killing me not to feed her. There are now, there's great data to support that actually doing that can increase mortality when we insert feeding tubes. So we ought not do that because we could cause more harm than good. If you want those papers, I'm willing to share that with you to show you those data. So you would want to make sure if that's something that you don't want happen to you, that you make sure that's documented in your living will, and that your durable power of attorney or your agent to speak for you knows that, so that wouldn't happen to you. That's just an example. Currently in the state of Ohio, that is the only legal way that we can deal with that. I hope I answered your question. It might not be the answer you wanted. Let me see here. Kim Preston. Oh, Kim, do you want me to address this to the entire group? Is Kim still on? Is Kim still
yeah.
on? Oh, I think she is.
Okay.
Okay. So Kim's question, is there an accepted MOLST, MOLST, or what we call medical orders for life-sustaining treatment form that is being used in Ohio? Any recommendations regarding use of MOLST or POLST? So unfortunately, Kim, we in the state of Ohio are one of the last states, in fact, one of the few last states to adopt this form, which is considered a medical order. The medical order or MOLST form, it's also called POST, Physician Order for Life-Sustaining Treatment. And in some states, it's called POST. In West Virginia, it's called POST, for example. But that is a really important document. We attempted to shepherd it through our Ohio state legislation over a number of years, and it failed. And to our knowledge, it is not going to be resurrected in the state. It's quite unfortunate because it does allow for the DNR order and the living will and durable power of attorney, if you will, to all be compressed into one document, so that that medical order, the whole document itself serves as a medical order, and it helps direct even emergency personnel when they're called to your home. The other powerful thing about MOLST, POST, and POST is that it's portable across care settings. So if I have MOLST established in the nursing home and I fall and EMS is called, it's most often, you all, that my DNR doesn't go with me. It doesn't go with me to the emergency room. So once I get to the emergency room, no one knows that I have a DNR or do not resuscitate, because it didn't follow me, because it's not portable. With a MOLST, it would be portable. And that is the true beauty in MOLST. But for a lot of reasons, that would take way too long to discuss, and perhaps we can have an additional conversation about this. It does not currently exist in the state of Ohio. I hope I answered that question.
And I'll chime in there to say that that's an important reason to pay attention to legislation and work with your legislators, because we believe this is a piece of legislation that Ohio should have, and they're not hearing from enough people who also believe that. So we need to start telling our leaders, our legislators, what's important to us.
The very to restart. Okay, so it's Barbara Thomas from Kendall at Oberlin is with us today, and she has submitted a question. Go Wish is used and beneficial to Kendall residents. I'm glad to hear that, and I'm glad it's being used. What are your thoughts on Ohio's requirement that residents who are on hospice must be at the very end of life to receive family for a visit? Barbara, I'm assuming you mean in the current climate and environment we have with regulations of due to COVID-19. Is that correct? I hope that's what you meant, because otherwise that's not correct. So if that is correct, what are my thoughts? Well, this is tricky. I've had a couple of text messages from just community members who have friends, who have family members in hospice, and they're saying, Maryjo, they're not letting, Carol in to see her dad. And that is really difficult for long-term care facilities or assisted living facilities who have hospice patients inside of those walls. And then they have a relationship with outside hospice providers that are coming into their institutions to augment and provide the hospice plan of care while living in that facility as their home. And that's tricky, because you've got perhaps 75 to hundreds of other people who are living in that space as their home who aren't on hospice, right? So you have to make a decision as providers of a facility, and really that goes to what is the greatest good. And those are very tough ethical decisions to make, and balance the beneficence of doing good and not doing harm. And remember, an ethical dilemma is just that. It's making the best choice out of all choices that seem wrong. And I know that's very hard, and I know that the use of technology has not served us better than any other time when it's come to hospice care and when it's come to extubating these patients in ICUs, and allowing family members to say goodbye to their loved ones who otherwise would not. I mean, what would we do without this thing, right? What would we do without this to be able to use it? And so I say, use the Zoom camera if you can, and use technology. Any other questions, Lisa, that you can see on here?
So Kelly has one for you about getting into hospice and palliative care, but maybe Kelly, you and Maryjo can talk, separately after this. That might be a good thing. And then Susan notes that it's interesting that women are participating in this. What is the interest overall with males with this issue, especially since so many of our legislators are male? And I think it's fascinating. I agree with you. And I think it's got to have a tie to the fact that women are so often the caregivers. That would be my take on it. So we absolutely, in other states, we seem to have more males involved. There's some states that have males that's the leader of like an organization like this. I would be interested to know about that too, because we know that, again, everybody dies and everybody has experiences, and somehow the women are the ones who are talking about it and exploring it with us. It's not always the case. But when we go talk to legislators, we do try and bring with us your stories. And we ask you to contact them as well, so that they have these stories that really open their eyes to the relevance of this issue that maybe they haven't thought about before.
Yeah, Susan, you're asking really thoughtful questions. And I think I concur with Lisa that, most caregivers are women. And also, if you're in nursing, or if you've come to us from nursing, which I know I know there are some nurses on here because I know you. It's a primarily female-dominated profession, and that doesn't mean that, as Lisa said, we're all going to die, whether you're male or female, and we all have to have these conversations. I think we also know that women naturally just are more conversational than men, but I think these platforms offer some different types of opportunities and means to engage in these in a non-medicalized way, in a fun way that, sometimes you can just laugh over some of the answers that people say, and it stimulates other questions. And it doesn't have to all be serious. Like when you think about how we're birthed, we don't talk about it that way. Yes, because it's life. But think about this as life just leaving. And we should be celebrating it in a way that has humor. It helps us. It helps us cope. So I don't know if I answered that question either. Susan, I'm not really answering any of your questions. Hopefully I'm giving you some things to think about.
So
Does anybody have any additional questions about the documents? The actual documents. The living will and durable power of attorney for healthcare documents. Sorry, I should have been more clear.
I think if you come across them, you know, you can feel free to get a hold of us, and we can pass that along to Maryjo. I think that we can go ahead and wrap up. Like I said, I'll try and get in contact with all of you for feedback about this today. I'm going to leave you with a story of my own, one of my favorites, and a prompt to go even beyond this conversation to the next steps of your conversations. My mother has a pink folder in her home that's got all of the relevant information, including her funeral planning. And my story is about my beloved grandmother, who I was her healthcare power of attorney. She lived in another state. It was a very difficult course for us over time, but she and I had some amazing conversations. And I went into one of them so nervous because her money was running out, and she had been the saver in her family. And she and my grandfather owned a service station. So cars were gigantic in their lives. That's sort of, you know, how they gauged life, is what type of car they were able to afford and other people afforded. And so it was my turn as her healthcare power of attorney and her financial power of attorney to talk to her about money, and how I thought it was time for her to start prepaying her funeral planning, which is controversial on its own, but that's what we were doing. So I had invited a gentleman to join us to go through that process. And I was so nervous about bringing this up with her. And yet at the same time, I had been with her when my grandfather died, and he was a Purple Heart veteran. And so he was buried in the Veterans Cemetery. And she knew there was a place for her alongside him. So I knew that, she knew that it was very important to them. And I went into saying, Grandma, you know, we've got to start doing this. We've got to work with your money, and we have to plan this ahead of time. And so that gentleman had brought with him a binder of caskets. She wanted to be buried. She didn't want to be cremated. And we paged through this booklet of caskets. And here I was so nervous about this. And she sort of perked up and started saying, like, oh gosh, that's what we chose for Uncle Charlie when he died. Now, my grandmother had buried a lot of family members, including 3 of her 4 sons when she died. So she had a lot of stories. But when she picked her, you know, I love this, look at that color, I like that blue. And I said, Grandma, you know, I'm so sorry to say it, but that's kind of a Cadillac, and you don't have the money for that. And she said, oh, well, just bury me in a pine box then. I said, no, there's options here. So we had this wonderful discussion. She picked out her casket. I then had a card in my wallet that had all of the information, so that when she died, I was able to call that number. And in fact, it was as easy as all get out. And all of those decisions had been made. And when I saw her powder blue casket, it brought a smile to my face, because we had that special moment that I didn't expect to be so special. And I knew what her wishes were. So even though these conversations seem difficult, I can tell you they can end up being quite special. So whatever conversations you choose to have, we just encourage you to have them. So I truly thank you all for joining us. Please give us feedback. Please continue joining us and sharing these with your friends so that we can make a difference across Ohio. Thank you very much, everyone.